can start.
Okay. Good afternoon, everyone. Dr. Sunita has an urgent call and he will be joining us a bit later. Welcome you all to the fifth ISN OSEA case discussion. Today we have an interesting case from Salanyang Hospital presented by Dr. Esther Tan, but actually her name is very long, Tan Sao Chi.
Yeah, Malaysian Chinese name are also very long.
Thank you for being here and let's get started. We have 1 hour. If you have any questions or you want to raise any comments, please text to us. Thank you.
Okay, thank you, Goff, for the introduction. I forgot to put that I'm from Malaysia. I just realized that this is international. So today I'll be presenting a case that you may or may not see in your course of managing PD patients. So we have a 39 years old lady, Madam K. She was diagnosed with lupus nephritis in 2015. Then she defaulted follow-up until 2018. A renal biopsy in August 2018 showed thrombotic microangiopathy with activity index of 6 and chronicity index of 10. She was then treated with IV cyclophosphamide, 4 doses, but there was no response, and then she was converted to mycophenolate mofetil. Eventually, in January 2020, she developed end-stage kidney disease and she was initiated on self-care peritoneal dialysis. She started with 4 exchanges of 1.5% with a dwell volume of 1,500 mils, and her ultrafiltration was 800 to 900 mils per day. So January 2020, she started on CAPD. In March 2021, a year plus later, she presented with PD peritonitis, which was culture negative. She was treated with intraperitoneal cefazolin, ceftazidime, and gentamicin for 2 weeks. So then after that, in November 2022, which is more than a year later, she presented with a 3 days history of abdominal pain and diarrhea with also a cloudy PD effluent. She then absconded from the emergency department and was uncontactable. She presented later on, about a week later, to PD unit and because her symptoms were not resolving, that's why she came. So she received a loading dose of intraperitoneal cefazolin, ceftazidime, and gentamicin with oral fluconazole. So on day 3 of presentation, her PD fluid cultures grew Streptococcus aeruginosus. She was treated with IPC penicillin for 3 weeks at that time with oral fluconazole. So about 6 months later, she presented to another hospital treated for PD peritonitis with IP cloxacillin for 2 weeks from 1st to 15 March 2023. Her PD fluid cultures then was no growth as well. So this was her 3rd episode of PD peritonitis. So the targets for culture negative PD peritonitis rate should be less than. I don't have Slido, nor do I have any polling. So if one of you can unmute yourself and answer, that would be great.
So we can text.
Oh, can text. In the chat, is it?
Yeah, in the chat. Yes.
Okay. In the chat also can. But I can't see. Someone answered. Okay. So HKL answered 15%. So all of you know. So should be less than 15%. It used to be 20%. So now it's less than 15%. So this was based on the ISPD 2022 guidelines. Okay. So a week after that, she presented with leg swelling, autopnea, reduced effort tolerance. Her body weight increased by 9 kilos over 2 weeks, from 43 kg to 52 kg. And her usual daily ultrafiltration has dropped to about 200 mils. She was hypertensive, and clinical examination shows that she has a fluid excess. So PD regime was adjusted. We gave her icotextrine, gave her 2.5%. So the total UF was about 800 mils on this regime. Left pleural tapping was done. You could see that she has a pleural effusion. She has also cardiomegaly. There was no evidence of RV chamber collapse, but there was a global pericardial effusion. In view of underlying history of SLE, anti-DS DNA was sent, which was negative. The pleural tapping was transudative on the left side with a glucose of 5.8. So then she was diagnosed as major depressive disorder by psychiatry. We found out that she has certain social issues ongoing at that time. That's why then she was started on antidepressive medications. So less than a month later, she presented in April with 2 days history of turbid PD fluid, vomiting, diarrhea, and abdominal pain. That time she was hypotensive and tachycardic. Chest was clear. She was resuscitated with fluid. At that time, they upgraded her to IP intraperitoneal carbapenem, amikacin, and they gave a stat dose of IV vancomycin and treated her for septic shock. So this was a chest X-ray, much better than before, although there's still a little bit of left pleural effusion there. After treatment, the PD fluid cultures actually grew ESBL E. coli. So she complained of drowsiness with IP imipenem. So she was switched to IP meropenem and IP amikacin. Then she was doing 1.5% 3 bags, 7.5% 1 bag. Her UF in total was 335 mils per day. So her alkaline phosphatase level then increased from 272 to 1034 to 2517. Gamma GT was slightly raised. Bilirubin was a mixed picture. So an ultrasound abdomen in April 2023 was done, which showed loculated ascites with internal septations and subhepatic complex fluid collection. So what is the possible diagnosis? Maybe you all can put in the chat.
No, I think we should allow friends to assess and list the problem. So any volunteer from Faro, maybe start from Thailand, Singapore, Indonesia, Philippines.
Actually, we can go back and you can comment on, you see, the ultrafiltration has dropped to 335 mils, but this was during the PD peritonitis episode. But yeah.
Do you want to ask about the
This is
okay.
This is a first year fellow from Thailand, Chulalongkorn Hospital.
Oh, hi.
Yes. The problem is in this case is a 39 years old female who has lupus nephritis, turned ESKD and on PD since like 4 years ago, and she has history of recurrent peritonitis, and suspected of UF failure during last year, and I'm not sure that she has history of left pleural effusion with pericardal effusions, and also diagnosed of depression disease, which I'm not sure if this is the disease flare or anything, but later on the effusion seems to improve. And for the last episode, she developed another episode of peritonitis, which is E. coli ESBL during the April of last year, and then developed of alkaline phosphatase rising and loculated collections in abdomen. So I would like to approach for the last problem that she has a loculated ascites and also the rising alkaline phosphatase. So the differential diagnosis, I think, is like she had this due to she has recurrent infection in the abdomen, so she might develop the loculations secondary to the infection, which is, I'm not sure if it's refractory or is it the same disease that is drug resistance. And also with the alkaline phos rising, we have to look for the liver lesions such as liver abscess or any infiltrative liver disease, or maybe the drug that she was given during this time. So we have to review that also. So right now, I would like to have an imaging of the liver to exclude the space occupying lesion, or such as liver abscess or anything that's occupying the liver.
Yeah, so the ultrasound showed that. What other imaging would you like to do?
Okay, so the ultrasound doesn't show any liver disease, right? It's only
So,
that collection.
but the alkaline phos is still 2,500. So apart from ultrasound, is there any other imaging that might be a little bit more sensitive? Maybe someone else can answer.
Pardon, can you repeat again?
Apart from ultrasound, so let's say you are seeing this patient now in your clinical practice. So you rightly proceeded for an ultrasound. Ultrasound abdomen, they do look at the liver. So, but this was the comment given by the radiologist. So there is a subhepatic complex fluid collection. So what we are worried is whether there's a liver abscess, right? So, but this is subhepatic, it's below the liver, and there's loculated ascites.
So
I
it's
would like to
where is the
request
loculated ascites? Where in the abdomen of the loculated ascites?
They didn't comment, but definitely they say below the liver there is a subhepatic complex.
Okay.
Yeah.
Below subhepatic. So anyone or any fellow want to raise any diagnosis or any comments or any voice? No. Maybe no. Any fellow too? Second year fellow? And someone text that they request for CT scan.
Yeah. I would proceed for CT scan because that's what I did because I wasn't happy with the ultrasound findings. So we also worried about intrahepatic cholestasis. So we actually switched the fluconazole to syrup nystatin. So we did a CT tap. So this is the CT findings. There was smooth thickening enhancement of the peritoneum, representing because she's still having ongoing peritonitis at that point. There was a presence of dilated jejunal loops, which appear encapsulated at the left upper abdomen. So they suggest that this may be due to peritoneal sclerosis. There was no calcification seen. So it's just a loculated collection. There is a thickening and enhancement of the peritoneum, and there is an encapsulation within the thickened peritoneal sac at the left upper abdomen. So despite that, we also proceeded for endoscopic ultrasound, which is useful when you have a raised alkaline force to look at the pancreas to see whether that it could be the cause. So the pancreas was normal. The common bile duct was not dilated, so there was no common bile duct obstruction. Eventually, the alkaline phosphatase actually returned to normal. So I wasn't sure whether it was actually due to drug related. So she was diagnosed with encapsulating peritoneal sclerosis, but she refused conversion to hemodialysis. Her PD effluent cleared up. She completed the IP meropenem on the 12th of May in 2023. She was started on tamoxifen and also prednisolone.
Can I stop you for a while? So how many days that you give the meropenem?
21 days. Yeah.
Oh,
So
21.
12th of May was 21 days. Yeah.
And so the impression of high isolated alkaline phosphatase is drug related.
Probably drug induced.
That
Because this
induced.
after all the tests, the alkaline phosphatase returned back to baseline in I think a week or two.
And how
After
about
we switched the drug from
how about
fluconazole
intact?
to nystatin.
How about intact PDH?
The IPTH was not very high. I have it later on. I mean, it's between 15 to 30 picomole.
Okay, good. Thank you.
So she was treated and started on tamoxifen and prednisolone for 4 weeks and then taper every 2 weeks. So she completed IP meropenem on the 12th of May. So on the 20th of May, 8 days later, she presented again with vomiting, abdominal pain, turbid PD fluid, maculopapular rash. She was treated with IP meropenem and IP amikacin. In view of the rash, did a skin biopsy which just showed possibly dermatitis with eosinophils. Not sure whether it's cutaneous lupus or allergic dermatitis. ANA and TDS DNA was negative. She was treated with topical steroids and it resolved. Her PD fluid cultures again grew ESBL E. coli. So the peritonitis.
Marjorie asking you about any other test to confirm EPS?
The dialysis vintage that time 2020, about 3 years. Any other tests? No, we didn't do a laparoscopic biopsy. We didn't. It's just a CT scan. Yeah. Okay, so her PD fluid cultures grew ESBL E. coli. So the peritonitis on the 20th of May, which is the second peritonitis, what do you think this peritonitis is? Is it relapsing, repeat, recurrent, refractory, or none of the above?
So you want fellow to discuss again, or you want us to text in the chat?
This is actually quite straightforward if they followed the trick. You can text, you can unmute and say also can. Okay.
Relapse PD peritonitis.
Okay, relapse. Thank you very much. Because it's within 30 days, right, of completion of therapy. So that's why I mentioned upon completion of therapy, 8 days later, she came back and relapsed with the same organism. So PD effluent clear with the treatment of IP meropenem, and she agreed then for conversion to hemodialysis because the ultrafiltration was poor already. So we inserted a cuff catheter via the right internal jugular vein, and the Tankoff catheter was removed after she completed the treatment. We treated for 21 days. In between, you have to stop me if you want to ask any question because I cannot read the chat. Yeah. So then that was in 20th of May, and then she was converted to hemodialysis. Then in October 2023, she presented to the surgical ward with progressive bloatedness and vomiting. Her body weight then was 40 kg. So it was 43 kg in May. She lost about 3 kg. Abdomen was soft, minimally distended, non-tender, and they could palpate a vague mass, at the lower abdomen. So she was treated with IV cefobit and metronidazole. The blood pressure then was 167/90. So they did a CT abdomen that time. Anyone want to comment on the CT abdomen? Are you comfortable commenting? Oh,
Yeah. We should.
can
Okay.
I think it's more obvious than the previous CT. Now this one.
Please introduce yourself before you comment.
Yeah.
Hi, afternoon, Dr. Esther. I'm Ken from HKL.
Hi.
So the abdomen looks like a cocoon abdomen. Probably it's the late stage of your EPS already, around the encapsulating or the ileus part already.
Very nice. You can see dilated jejunal loops. You can see the encapsulating. So the report was worsening of small bowel dilatation, mainly involving the jejunum, and it's encased within the slightly thickened surrounding membrane at the left side of the abdomen as seen previously. There was no significant abdominal or pelvic lymphadenopathy. So what the surgical team did was they put in a Rouse tube. Conservative management did counsel the patient that may need surgical intervention if the symptoms recur. The symptoms improved, and apparently she could eat during the inpatient stay, and then she was discharged. So she presented in October 2023. So they followed her up actually monthly in their clinic. So there was one encounter in emergency department in November for colicky abdominal pain, and then when they saw in December, the symptoms were stable and the patient was able to eat and to open the bowels daily. So I thought I would discuss a little bit about peritoneal sclerosis here, since this is a teaching session as well. So one of the major shortcomings of peritoneal dialysis is the...
So are you gonna finish, right?
And not yet. The case still ongoing.
Okay.
In between our slot in, yeah. So the case haven't finished yet. It's still ongoing. So one of the problems with peritoneal dialysis is the progressive transformation of the peritoneum with long-term PD. So even 1-2 years of PD, you can see signs of peritoneal fibrosis. I think the Japanese group felt that using neutral pH, then this may slow down the peritoneal fibrosis in the patients. So what happened is that it is uniform change of the peritoneal membrane. There's a loss of mesothelium and the progressive thickening of the submesothelial layer as the PD duration is prolonged. And the blood is supplied actually from the artery to the capillaries, and the capillaries in the peritoneal lining represent the main site for your solute and fluid exchange. So your post-capillary venous are where the sites for exposure of this glucose-containing dialysate, and there are most significant changes as the PD PD therapy progresses. So you can have progression of vasculopathy, thickening of the vascular wall, as well as luminal obstruction at that level of your post-capillary venule. So if you can see, if you can appreciate the picture A and picture B, that there's a structure at the beginning of therapy and the structural alterations after 5 years on PD. So the mesothelial cells are detached, progressive peritoneal denudation. They undergo what we call, some papers say EMT, epithelial to mesenchymal transition. Some papers say mesothelial to mesenchymal transition. So they acquire a myofibroblast-like phenotype, and this has a progressive peritoneal collagen deposition and fibrosis, and all this leads to reduced osmotic conductance of glucose, ultimately leading to ultrafiltration failure. So simple sclerosis happens in virtually all patients because moderate fibrosis without inflammation, but EPS is rare, and in EPS there is some component of inflammation, and in simple sclerosis usually the patients are asymptomatic, but in EPS there's a 50% up to 50% mortality rate. So when you look at the pathogenesis of EPS, they think that there's two hit theory lah. So the first hit is when you develop after years of PD, you develop simple sclerosis, and then suddenly there's a second hit where there's an acute cessation of PD, where there's transplantation, or there's a frequent peritonitis, or there's a genetic predisposition, and then they develop cocooning and fibrosis and adhesion formation with encapsulation of the bowel, and they develop EPS. So the risk factors that is the strongest, it appears to be the duration of PD. I think that's why Prof. Marjorie asked in the group how long this patient was on PD. So the increased incidence rises with the duration of PD. You can see that if, based on the Japanese series, after 8 years of PD is 2.1%, but after 15 years on PD, it can go up to 17.2%. So there are other risk factors that are postulated, such as acute cessation of PD, because some of the cases are seen when they discontinue PD to do transplant. So post-transplantation, especially if they are on CINI-based therapy, peritonitis, genetic predisposition, and some of them when they have intraperitoneal lavage with disinfectant like povidone iodine. There are also other non-peritoneal dialysis related cause of EPS, just for knowledge here, like peritoneal intra-abdominal malignancies, endometriosis, and even abdominal surgery. So the duration of therapy seems to be the most important risk factors. But having said that, so some of the Japanese group, they actually lavage the patients after discontinuing the PD because they think that by doing the lavage, it will limit the accumulation of the factors that encourage development of the disease. But then there's a higher risk of developing peritonitis from there. So in 2000, the ISPD committee actually defined EPS as a clinical syndrome. So it's a clinical syndrome. Patients have to have symptoms of persistent, intermittent, or recurrent intestinal obstruction, and the existence of peritoneal thickening, sclerosis, calcifications, and encapsulation, either confirmed by diagnostic laparotomy or laparoscopy or radiological findings. So it's important, clinical symptoms plus radiology or anatomic criteria or macroscopic findings. Okay, I move on because I actually prepared for quite 1 hour. So diagnosis of EPS, CT scanning is the investigation of choice. So just for knowledge, I just show you here because my patient didn't have calcification. So in some patients, you can see the calcification marked by the white arrow. So the black arrow is marking the thickened, enhancing peritoneal membrane. So so you can see the thickened membrane all marked by the white arrows. Then you can have teetering of the bowel loops. Sometimes the purple arrow shows there's an enhancement there. You can see that it's a bit hyperdense. So, but there's a caveat. So if let's say CT findings, you can see all this, why not screen all our PD patients, with annual CT scan? But you see, CT scan of asymptomatic PD patients is not recommended because EPS may occur, within a year of the normal CT scan. And it's a diagnosis based on clinical symptoms. So you have to have the clinical symptoms. So not every patient that has any abnormality on CT will go on to develop the established EPS. So because of this, when you diagnose, you always have to take history and physical. Labs, you can send, they tend to have low albumin, elevated CRP, so they're inflamed. And these are the macroscopic finding. If you do exploratory laparotomy or laparoscopy, you can see that marked by the purple one up here is the thickened parietal peritoneum held up by the surgical clips, and then you have the visceral peritoneum that is thickened, forming a fibrous cocoon encapsulating the bowel. And when you peel the visceral peritoneum off, in a yellow arrow here, you can see that the small bowel has a brownish tanned leathery appearance. And actually, if you can send off a specimen of that, you can see a lot of fibroblasts and collagen deposition, as I show you in the much earlier slides. So the Japanese, they're quite innovative. So instead of, we cannot be doing diagnostic laparoscopy or laparotomy serially to monitor our patients, right, for EPS. So they actually came out with this ultra fine endoscopy, which can fit into your Tankoff catheter. So I think it's still a pilot trial. This paper was published in 2023. So they put the scope through the Tankoff catheter and serially just monitor the appearance that they can see. So in the figure D and E, you can see that, in E, you can see that there's a cotton-like appearance of fibrin on the peritoneum, and whether this will assist in monitoring patients at risk of developing EPS. So when you have a patient that is suspected EPS, always go back to your clinical history, taking symptoms like early satiety and examining physically. So if the CT is consistent with EPS, then you proceed with staging and treatment. So they stage the EPS. I think the Japanese series have the widest experience in terms of EPS because their patients are on PD very long. So they divide it into 4 stages. Actually, stage 1 is pre-EPS stage. So stage 2 is inflammation stage. Stage 3 is encapsulating stage. And stage 4 is ileus stage. So in the pre-EPS stage, sometimes the patients are asymptomatic. You can have intermittent bloody dialysate. You can have loss of ultrafiltration capacity. They can develop a high transport if they have been low transport to begin with. But generally, they are asymptomatic. When you have the inflammation state, they have leukocytosis, fever. Sometimes they come in diarrhea and ascites. They present like peritonitis. So it's an inflammatory stage. They are symptomatic with nausea and diarrhea, consistent with partial encapsulation, and there's mild inflammation and fibrin exudation if you examine them laparoscopic or laparotomy. So the third stage is the encapsulating stage, where the inflammation has reduced. They have signs of ileus already. So, and encapsulation is also present. So they have symptoms of bowel obstruction due to the formation of the fibrous cocoon causing encapsulation, and then there's ileus forming. The last stage is the ileus stage. They are anorexic, they have lost weight. When you palpate, there's abdominal mass. So they're unable to eat. So they're absolute bowel obstruction caused by thickening of the encapsulating fibrous cocoon, and anorexia. So which stage do you think this patient is at the moment?
Oh, we can answer by text, right?
Yeah, I think you can answer by text. You can put in the chat.
Yeah, anyone want to respond?
I think this patient stage 3.
Stage 3.
Can you
Any
give
different
a
answers?
reason? Can you give a reason why you
Stage 2
choose
going
stage
to
3?
3. Okay. HKL says 3 or 4. 3 or 4. Okay.
3 or 4.
3.
Yeah.
Yeah. So in general, everyone says it's 3. I agree with that. Okay. So so that was in October 2023. 6 months later, in March 2024, she presented with 1 month history of vomiting, abdominal distension, dizziness, weight loss, 10 kilos. She was 43 to begin with, 40 kg in October, and now she's 30 kg. Blood pressure has dropped actually. Her usual blood pressure was about 150 to 160 systolic. Blood pressure is 120 over 90, heart rate 84, oxygen saturation then 97%. And this was a heart size. You can see very nicely the pleural effusion has resolved. So her chest was clear, but her abdomen was now distended with generalized tenderness. At that time, her fistula was also functional. She has a right BCF that was created. And you actually, on the abdominal x-ray, you can see the dilated bowels. So she was admitted to surgical ward, and then she was hypotensive. She was planned for hydration and home TPN, but in view of the hypotension, they could not proceed for hemodialysis. So, and she was on IV noradrenaline and oral midodrine, so she was transferred to nephrology ward. So this was her lab results. Yeah, her hemoglobin is 14.4, partly I think due to the dehydration. Her urea is 44. Creatinine is 913. She has metabolic alkalosis due to the vomiting. Bicarb is 39, pH is 7.47. Surprisingly, albumin is 37.4. So her alkaline force is back to a baseline of 150. CLP was 3.41. So body weight dropped even further from 30 to 27 kg. Her BMI was 11. They were worried about refeeding syndrome, 1 month history of vomiting at home. So she was started on TPN at low dose at 10 kilocalories per kg per day. She refused surgical intervention because the surgeons told her that high likelihood that she will have a stoma created. So she flatly refused. So that was March, and she is still inpatient in July. In July, we started TPN April, May, June, July, so 4 months. So in July, her weight was around 31 to 32 kg. I started her on everolimus. She developed catheter-related infection on the 18th of July. All the lines was removed. She was treated. She was on total parenteral TPN, but about 25 kilocalories per day. So because already 4 months in the ward, I was thinking of a home-based therapy and trying to switch her to intradiatic parenteral nutrition, but she was not tolerating well and she needed to be switched back to full TPN. So echo showed ejection fraction of 40 to 45%, no pericardial effusion. Because of the catheter-related infection, we do an echo just to make sure no infective endocarditis. And this was her lab results in August. Her hemoglobin then was 9.3, urea 25.3, creatinine 706, albumin 38.1. Phosphate is about 2.25. CRP is down to 0.34. So now it's November. So she's been inpatient since March to November. So this was her latest results on 29th of October. Hemoglobin is 10.5, albumin is 40, phosphate is 2.30. The everolimus level was 1.5, so we pushed it up a little bit to 0.75 milligrams BD. She's actually on hemodialysis 3 times a week, sometimes twice a week. So she developed fever on the 7th of November. Her central blood cultures grew ESBL, E. coli, peripheral blood cultures grew cons. So she was on the triple lumen for the TPN. So she was treated with meropenem and vancomycin. We've discontinued the everolimus. She's now on regular hemodialysis via the fistula and still ongoing daily TPN. She's being co-managed with palliative care. Okay. Any comments before I continue on the management? Nutritional support is intravenous TPN. She has oral nutritional support as well, but she refused. So she is actually eating. She is on steroid, now on low dose, 7.5 milligrams once a day. Every day she is eating. She eats whatever she likes, but she vomits. So she will take very small meals so that she will vomit less.
Hi, Dr. Esther.
Yeah.
For the everolimus, is there any specific level you targeted for her?
Yeah, I was going to go through it in the management. It's based on one case report, so they target it to a level of 4.
Thank you.
So I will go through the management. You can put on, and still got comments I can read. Regaining body weight. She was 27 kg at her lowest. Today, just now, she's 33 kg. Suitable for SOS kidney transplant. This one I also discussed with the transplant team. Not easy. Yeah, she's not on intradiatic parenteral nutrition. She's on full TPN at the moment. So retrospectively, in this case, I would have converted her to hemodialysis earlier. I'm not sure whether you would. Yeah, because she had that bout of peritonitis, and the CT already showed the bowel dilatation in the jejunal part. At that point, she refused conversion. We did start her on tamoxifen and prednisolone. Then she came back again with another bout of peritonitis after that. Okay, maybe I continue, finish the management part, then we can discuss a bit more about this case.
Yes.
Okay. So management of EPS, PD discontinuation, nutritional support, medical treatment, and surgery. So cessation of PD should be done as soon as the diagnosis of EPS has been established. But like I mentioned earlier, they said that when you discontinue PD, there is also a risk factor of developing EPS because you have all these pro-inflammatory mediators, that will increase suddenly. They are not being washed out. So some of the Japanese series, they do a peritoneal lavage after discontinuing PD because it helps with mesothelial cell layer recovery. But given the risk of peritonitis with the peritoneal lavage, most of the time they say it's best to stop PD at the time of diagnosis of EPS, along with removal of the PD catheter. So nutritional support improves survival with total parenteral nutrition with advanced EPS. However, TPN on its own does not have any curative effect. So there's no recovery in patients treated with TPN alone. Is best suited as an adjunct to more definitive treatment in EPS patients. The definitive treatment is usually surgical intervention. So corticosteroids are particularly useful in the treatment of EPS in its early inflammatory stages. Steroids possibly act by suppressing inflammation. It helps to prevent and reduce the accumulation of ascites. But the response in the later stages of EPS is not so effective. So this is just to show the range of steroid doses used. Some of them use methylpred, some of them use prednisolone. And the staging of the I summarize it here lah. So the mean PD duration was 102 months. The daily corticosteroid dose ranged from 2.5 to 60 milligrams. Mean maintenance period was 8 months. Some even use it up to 3 years, 36 months. So when they stage it based on the 4 stages of EPS, you have a pre-EPS stage, inflammatory, encapsulating, and chronic stage of EPS. This is the distribution of the number of patients in this study. So the recovery rates was higher if patients were still in the inflammatory stage, about 79%. But subsequently, when it goes down to the chronic stage, recovery rates with steroid is lower and the mortality rates are higher. So the dosing are not well established. Some methylpred boluses for 3 days, then you give 0.5 to 1 milligram per kg per day for 1 month, taper the dose for a total duration of 12 months treatment. Some give 0.5 milligrams per kg per day for 2 to 4 weeks, then they slow tapering over months depending on clinical symptoms and signs of inflammation. So tamoxifen is a selective estrogen receptor modulator with anti-fibrotic properties that is used in the treatment of various fibrotic disorders like retroperitoneal fibrosis. So experimental studies showed that it blocks the mesothelial to mesenchymal transition induced by your transforming growth factor beta, significantly reducing your peritoneal thickness and reduce in angiogenesis. However, in most of your EPS patients, tamoxifen has always been used in combination with corticosteroids. So just the efficacy of tamoxifen alone still remains to be evaluated, and there's also potential side effects. So deep vein thrombosis, endometrial cancer, and infections with calciphylaxis, you don't use it. So those are based on case report and case series. You can see the numbers are very small. The largest one, the present study, is the Dutch EPS study, 24 patients there. So the dose of tamoxifen also ranges. So the Dutch study actually demonstrated significantly reduced mortality in EPS patients treated with tamoxifen compared to not with tamoxifen. So in the tamoxifen group, half of them was on prednisolone, and in the group that is not on tamoxifen, also half of them was on prednisolone. But it's a retrospective study. So the dosage of tamoxifen varied between 10 milligrams once a day to 20 milligrams twice a day. And interestingly, there was no surgical intervention in any of these patients. They were treated with tamoxifen for at least 4 weeks. So you can see that the group that was on tamoxifen had fewer deaths compared to the group that was not on tamoxifen. So most studies use 10 to 40 milligrams daily. The Dutch EPS registries suggested starting with 20 milligrams BD. So clinical response is typically seen within 1 to 6 months. The treatment should be continued for at least a year. For this patient, I gave 20 milligrams once a day now. So she has been on it since last year. So how long to treat for? We had another EPS case that was converted to hemodialysis. We treated her with tamoxifen for 6 years. 6 years, then we were sure when to stop the tamoxifen. So when we discontinued the tamoxifen, she developed ascites. Then we had to restart back the tamoxifen. So there was a case report where they actually treated for 10 years with low dose tamoxifen, 20 milligrams per day. So what about other immunosuppressive medications? So a variety such as azathioprine, mycophenolate mofetil, your sirolimus, cyclosporin has been used to treat EPS, but there's a lack of robust randomized clinical trials. And the fact that, your EPS develops after renal transplant, and these patients are already receiving corticosteroids and CNI and mycophenolate. So that sort of argues against the therapeutic benefit of such drugs in the management of EPS. But then again, CNI are co-administered in these cases, and they are known to promote fibrosis. And there are retrospective studies that suggest that a transplant recipient has a 10% risk of EPS on conventional CNI regime versus a 1% risk on low-dose CNI and mTOR inhibitors. So in those patients that are at high risk of EPS, you might want to put them on a mTOR inhibitor-based regime. So based on their anti-proliferative action, they may be an effective treatment for EPS in combination with corticosteroids. They induce E-cadherin, thus inhibiting the epithelial or mesothelial to mesenchymal transformation. So this was based on a retrospective analysis of 1,048 kidney transplant done and 10 cases of post-transplant EPS. So actually they detailed out all the 10 patients. So 10 patients, 5 of them were converted to mTOR. Out of that 5, 1 patient died, and that 1 patient was the only one that was not surgically treated. So very hard to comment on the effect of mTOR inhibitor. So this is in the post-transplant series. This is one case report from the Italian group in 2014 on the use of mTOR inhibitor in a patient that was on hemodialysis. So patient was developed ultrafiltration failure, converted to hemodialysis, developed EPS 6 months later. They did laparotomy for adhesiolysis, confirmed on peritoneal biopsy. So he was treated with total parenteral nutrition. They started on prednisolone, everolimus. They started at 1.5 milligrams per day, adjusted to maintain a blood level of 4 and tamoxifen at 10 milligrams per day. The EPS resolved within 2 months, and he went on to have a kidney transplant. So surgery in severe stages of EPS. This patient now is already the severe stage 4. So surgical enterolysis, resection of it with division of adhesions may be effective to treat the intestinal obstruction. Mortality ranges from 19 to 34.5%. However, any adhesiolysis may induce further trauma, inflammation, possibly also causing more adhesions and constriction. There might be a recurrence rates of about 25%. I think the Japanese surgeons are good at this. They have several techniques that they use, like noble plication, suturing of intestines to each other to prevent obstruction, which has reduced the recurrence rate to 12.3%. So this is how you find the cocoon abdomen in figure A, and after complete enterolysis, where they actually relieve the bowels from the cocooning so the bowels can move freely. So this is a summary slide. So when you have a patient with EPS, to stage 1 to stage 4. So I think the best is if you can catch them at the inflammatory stage. So you treat the underlying cause at the inflammatory stage is where you want to consider using your corticosteroids and tamoxifen. Then, because once they reach the stage 3 and stage 4, the encapsulating and chronic ileus stage is going to be supportive care. Even TPN is supportive and adjunct to surgical intervention. And without definitive surgical intervention, like I think in my in this patient of mine, I think death is certain. Okay, I think that is the last slide. I will stop sharing here and we can discuss.
Yeah, we have 15 minutes Q&A, so
Yeah.
please feel free to ask any question or text to Easter. So, Dr. Min Ong Hien from Myanmar, he wants to ask, what's
Root
the root
cause.
cause? Yeah.
She was a very non-compliant patient to begin with. She has a complex social history, broke up with the boyfriend and had to move house. So I wasn't sure whether the moving around and the environment where she was doing the peritoneal dialysis was the best of the environment. So she had a lot of things going on with her for the last 2 years.
Anyone want to share EPS treatment experience from your
Yes, that would be good.
Can you hear me?
Yeah,
Yes.
much
Okay,
better.
good. Because I wasn't sure just now. Recently, we had a series of cases and we presented to Joanne Bachman, who came to us after the Dubai meeting, right? So we presented this case and it was very interesting. So just to recap for you, right? So in this case, when I asked you about, is there anything you can do to preempt or reduce the risk of developing EPS, right? So number one is, it noted that she was on CAPD, right? And then you use a lot of high concentration glucose to get the adequate ultrafiltration. And if you look at the literature, it says that when you one of the thing that happens as you proceed towards EPS is that you have a raised transport status. So maybe one of the clue is there, right? If you do, people don't do PET nowadays, but if you do that, you may see the gradual increase in the transport status. That's one way. That is how in the past the Japanese were doing it, right? And then they noticed that when the transport status goes up, then they convert the patient before they actually get EPS. And in this case, to prevent high glucose exposure, you may want to consider APD, may help, like glucose sparing with EN, etc. But this is just talking back, with the retrospectoscope here. The other thing was, you were saying the relapsing nature of the peritonitis, right? So I have no doubt that the peritonitis potentially is one of the target, that causes the EPS that starts the cycle rolling. So the question is that, was there any time during the time when you kept having peritonitis that you would think about perhaps a biofilm on the catheter and you want to change the catheter and put a new one in? I mean, I'm not sure, I didn't focus whether she actually had any time free of peritonitis where you want to consider, he's having a lot of peritonitis and maybe you just change the catheter or the biofilm. So that's one consideration. The other thing is, I mean, you did a very good talk on how to manage and everything. That's one of the things we were very concerned in Singapore is that that patient might want to ask you, I wasn't informed of this potential complication when I first started. They might sue you, right? Because even though it's very rare, but it is serious, right? 50% of patients at EPS will die within 6 months. So then we're also quite worried because we're having patients more, because we're in a way that your program is good, you keep patients longer and longer on dialysis, but you also have this higher and higher risk. So I asked Joanne, how did you deal with this problem? And then she said she has a 5-year rule, meaning that at the point of 5 years, she will sit the patient down and tell them that EPS is potentially a complication. And the patient would then decide at that point whether they want to change modality. All right. So the chances are that most patients, by the time they reach 5 years, they would probably just carry on, right? But then you've done your duty in terms of explaining to the patient there's a potential risk of developing EPS and what is the consequence of EPS, what is the consequence if you don't change, what's the consequence if you change. So this is something that we may want to, I am actually going to institute my program because we never tell the patient, but when we see so many of these, right, and they're young people, that's a worry. They are very young people. And the chances of them getting a transplant is very grim if you get EPS, right? You probably have to have a gut transplant, isn't it? So it's going to be quite sad. So I think, so these are the few things I want to mention. Okay.
Yeah, thanks. Yeah, we didn't have the opportunity to remove and reinsert. We normally do it if it's a relapsing peritonitis. So for her, we didn't.
Hi, I'm Lily here. Can I say something?
Yes, really, please.
Yeah, we rarely have EPS in our center. Currently we have about 400 PD patient, and our dialysis vintage is quite long, and some of them about 12 years, 13 years. But I think, like Marjorie was saying, the use of hypertonic PD solution, we really need to be careful in terms of not necessarily giving patients hypertonic PD solution like 4.25 or 2.5 so early if not required, because sometimes we tend to chase the ultrafiltration where despite patient having UF of 1004 with 1.5%, sometimes we tend to use 2.5% or even 4.25%. So I think from the start, we really need to, the initial prescription, we have to try to avoid using hypertonic PD solution unnecessarily. Of course, in our part of the region, icodextrin is still expensive and not readily available for everyone. And of course, the second hit is the frequent PD peritonitis. When we have EPS, if it's so severe like the one that Esther presented, usually I would use tamoxifen 20 milligram BD. Instead of daily. I use BD first, and subsequently, maybe after 3 months, I may reduce it once the symptoms are improving. I do not use steroids. But so far, my experience when I use amoxifen, it is suffice enough to actually where the patient does not progress up to the earliest symptoms. So I think that's my opinion, and we do not practice like what Japan does, where by 5 years they tend to convert the patient to HD, where they anticipate EPS is there. But our dialysis vintage, it goes up beyond. Our longest PD patient is 18 years and still using 1.5% 4 bags. So this patient is and the ultrafiltration is still good. So I think is the 2 hits theory, like the first hit is using hypertonic PD solution. The second hit is the PD peritonitis. We really need to prevent it very, very early when the patient starts on PD. Thank you.
Dr. Lily, we had one 20 years on PD using 1.5%, and then he received a cadaveric transplant. He developed EPS post-transplant. So that was the second hit, the transplant.
Oh, okay.
Yeah.
It's unfortunate.
So yeah, as Lily said, so actually we have second 2 hits. The second hit usually in Asia Pacific region, especially in ASEAN, maybe infection. And you mentioned that the patient have multiple episodes of infection, right? So, but the beginning is a culture negative, and finally we disclose it's a gram negative. I used to see many cases that refer to my centers that culture negative, and they develop that obstruction, and they refer to us because they explore twice and nothing to do with the bowel. So finally, I use PCR and sophisticate culture. So it's reviewed as Candida, gallbladder. But because after the long time of EPS, maybe the bowel perforation, and you can culture like a usual organism for peritonitis. The thing that maybe keep in mind, and the case that I've been treated is infected with the Candida for almost 8 years. And I used the tamoxifen for 10 12 years, and I monitor serum glycoman, still there, still high. So it's difficult to treat Candida sometimes. And any comment from the other country, from maybe Taiwan, Indonesia, Philippines, or Vietnam? Tete, do you want to any comment, Tete?
Yeah, hello. Can you hear me?
Yep.
Yeah. After talking so many kind of like complication EPS, I also have to share what I have a case EBS, but not all the EBS end up with a very severe complication. I have a patient like PD for 10 years, and then subsequently he developed EPS. So we managed to convert to the hemodialysis, and I was treated with the prednisolone and tamoxifen. Subsequently, he managed to get transplanted because he was PD for 10 years. So translated to HT for about 1 or 2 years, and he got the transplanted. Subsequently, he's doing very well. I think about 2 years plus already a transplant. So not all the EPS case has similar complication. So if we manage to pick up a little bit early, try to treat it early and persuade patient to convert to hemodialysis early. The time my patient was about 50 years old when he started dialysis about 40s. So yeah, just let you know that, yeah. So if we pick up a little bit early is important, try to treat it properly, convert to the hemodialysis early. And if this patient can get transplanted, the outcome something may be good lah.
Thank you.